Okay. So we began with true and false labor signs, right? Where we try looking at what we should be able to spot in our questions for us to know what entails true labor sign, false labor sign. Try looking at what station means when you are reading your question, what it means when we say station zero, station a -1, and then station, let's say +1 or +2, and what the significance. So we did all that. We came onto the periodic patterns when it has to do with fetal heart rates. We looked into all this, and then actions you need to take. We ended with this a general intervention for non-reassuring fetal heart rates. And so that was what we did, and then we did some few questions. We dropped it there, and so today we are to continue with stages of labor. Yesterday, someone wanted to know the consistency, how often should contractions be occurring, and when contractions occur, how long should it last for, and all that. And so I told the person that the person should just hold on. I have it in my next slides. And so today that's where we are starting from. We are beginning from the stages of labor, and then we are going to take it one after the other. We look at stage one and the phases. So when you take stage one, we have three phases. We have um, latent, we have active, we have transition. And so what happens at each of the various phases, that is where contractions and then dilation actually happens. And that is where they like asking the questions. Okay. And so the significance of what we are coming to learn today is that if you are reading your question and then a woman is at certain stage of labor or a certain phase of labor, and then contractions are occurring, what do you expect to see regarding that contraction? It is supposed to occur every 30 minutes. It is supposed to occur every 5 minutes. And how long should it last for? So if someone is in active phase and the person is contracting every 30 minutes, is it normal? Is it abnormal? Do you need to report? If someone is contracting every 60 seconds in transition, is it normal? Is it expected? Those are what we are to start with today. And then when we are done, we then go into some of the complications that could happen during labor. Then we look at the postpartum period and what happens in the postpartum period as well. Some of the issues that can occur during postpartum. Okay, so that is our objective for today. And then what we have to do or what we expect to do. So let's start. As we all know, we have 4 stages. So understand the difference between stages and phases. So we have 4 stages. First stage generally has to do with um, cervical dilation. And then stage 2 has to do with delivery of the baby. Stage 3 has to do with delivery of the placenta. Then the stage 4 is after you have the last or the immediate 4 hours after the placenta had been delivered. These are the stages. Then when you take stage 1, within stage 1, it has 3 phases. We have latent phase, we have active, and then we have transition. So now let's delve into it. So I said that stage 1 mainly has to do with cervical dilation and then effacement. Okay, so the cervix mainly dilates during stage 1.
Hello.
Okay. Yes, hello.
Please, your screen is not showing or the network.
Hello.
Please,
Is
are you
my
sharing your
screen?
screen?
Yes, I'm sharing. Is my screen showing or not?
Please,
Yeah, it's
sister,
showing.
check your connections.
It's
It,
showing.
it's showing. Okay, then
Yes,
Thank
Haja.
you.
please.
Okay, Haja, check your. You can leave and rejoin again. Okay, you can leave and rejoin, and you have. I mean, you can get it back. So I was on the first stage, and I said the first stage mainly has to do with the cervix dilating and the facing. And so when we say dilation, I just as we know, we say cervix will should I say expanding, we'll move from 1 to 10, right? Then effacement is the cervix thinning. The cervix has to thin to make it easy for the presenting part to easily maneuver its way through the cervix. Okay. And so that is the main job of what we call stage one. So stage one deals with effacement and dilation of the cervix. It has three phases, or if you want, you can equally say three stages within stage one. But not to get confused, you can put it as three phases of stage one. So we have latent, we have active, and we have transition. During this phase or during this stage, that's stage one, the mother becomes more talkative. Pain increases with time, right? And so the person becomes talkative and eager in the latent phase, become tired as well, restless, and then anxious, okay, as labor intensify and contractions become stronger. Now let's take the first phase, that is the latent phase within the stage one. And so the latent phase is the beginning of labor, right? The beginning. And so you have service. So this is where you have to pay attention. Within phase one, that is the latent phase, what is the extent of dilation of the cervix? So within
It's a
the
picture.
phase one, the cervix dilate from 1 to 4, right? 1 to 4 cm. Cervical dilation is 1 to 4 cm. So if you get the question and the question is about latent phase and they are asking what is the expected extent of dilation of the cervix during latent phase, you will see maybe 1 to 4 cm, 1 to 3 cm, 1 to 5 cm, and all that. You should understand that within phase, the first phase, that is latent phase, cervix has to dilate up to 4 cm, 1 to 4 cm. Now, another thing they also like asking is how often contractions occur. So contractions occur every 15 to 30 minutes. Okay. So within the first phase, that is latent phase, contractions should be occurring every 15 to 30 minutes. So the woman should be experiencing contraction or should get contraction every 15 to 30 minutes. Now, if you are reading your question and the question says that a woman in the latent phase, a woman had dilated 3 cm, but contractions are occurring every 5 minutes, understand that it is not normal. And so it requires you to inform the healthcare provider. If a woman who had dilated at 3 cm is contracting every 5 minutes, it is not normal. Then, when the contractions occur, how long should the contraction last before it ends? And so the contraction also should last for 15 to 30 seconds. So if you want a simple way to keep latent phase is 15, 30. So 15 to 30 minutes, that is how long it should be occurring. And then when it's okay, it should stay or it should last for at least 15 to 30 seconds, okay, in duration. In terms of the severity or in terms of how the woman will feel, I mean, the pain, it's more of mild in intensity. The pain the woman will be feeling, it will be mild in intensity. So that is on latent phase. We said that cervix dilate up to 1 to 4 cm. Contractions occur every 15 to 30 minutes. Then contractions also last for 15 to 30 seconds. Okay. If someone is in the latent phase and you want to manage, what are some of the things you can do to assist the client? Remember, we said that if the person is in true labor, for the pain, no action can kind of resolve the pain. All that you do is to help the woman to cope with the pain, right? So you encourage partner, you can encourage the partner to be with the woman and then also participate in the care. These are comfort measures, right? So you assist with comfort measures, change of position, and then ambulation. Okay. And then you keep the client and the partner informed regarding, progress, and then you offer some fluids and ice cubes, and then you encourage voiding every 1 to 2 hours. Okay. Now you can get a case study where you have this kind of question. They will put that um something you can do. So actions you can do and then what you cannot do. So probably you can get your case study and then you have it in the latent phase. What are some of the things you can do? Encourage woman to do this. Is it done? If it's done, you take. Do this. If it's not done, if you think it's not done, you take it out. Okay. So these are some of the things that in the latent phase the woman is going to experience. And then what you can also do for the woman in the latent phase, okay, in terms of intervention for your clients in the latent phase of labor. Now, the moment the woman passes 4 cm, the woman is going into what we call active labor. Okay, so active labor, all those with your videos on, kindly put them off with your audio as well, unless you want to come in with probably a question or an inputs. Other than that, if you have your audio and your video on, kindly switch it off for us. Okay. So let's continue with active phase. So the active phase is where you have cervix dilating from 4 to 7 cm. Okay, 4 to 7. So at this point, that's why it's active. The labor is progressing. It is moving as expected. Okay, and over here, in terms of pain, it continues to increase. Okay, then contractions will now be occurring closer together. So now you realize that as the labor is progressing, then contractions will be occurring closer together. So again, if someone is in active phase, the person has dilated 6 cm and the person is contracting every 10 minutes, it is not normal. If the person is contracting every 15 minutes in the active phase, it is not normal. It requires you to inform the healthcare provider. Okay, so in the active phase, we want to see contractions every 3 to 5 minutes. And then when it occurs, now when the contraction occurs, it lasts longer. It lasts for 30 to 60 seconds. 30 to 60 seconds. And so here too, if someone is within the active phase and then contractions occur and the contraction lasts for 90 seconds, it demands you to report. So these are what I'm saying is how they ask the questions. So, okay, a client in active phase of labor contracting every 4 minutes, and then whenever she contracts, the contraction lasts for 15 minutes, 15, sorry, but the contraction lasts for 90 seconds. What will be the most appropriate intervention? Then you have A, continue to monitor. B, report to the healthcare provider. And C, a change position. And then probably maybe D, they say that assist the woman to ambulate. Okay. Now you should be able to know how should the contraction last for within active phase. And so 90 seconds is not expected. So 90 seconds means that it is lasting longer. So you should report. Okay, you should report to the healthcare provider. So contractions occurs every 3 to 5 minutes, and then it lasts for every 30 to 60 seconds. That is the expectation for a client within the active phase of labor. Pain is moderate in intensity. Okay, so pain becomes moderate in intensity. Actions you can perform for your clients will be to encourage them you maintain what you call active breathing pattern. Okay. So encourage maintenance of active breathing pattern. You provide a quiet environment. At this point, the woman is moving gradually. So you might have to keep the client's family informed. And then you can also provide some comfort measures by encouraging the partner to kind of rub their back and then apply some form of sacral pressure to support some the pelvics and all that, pillow support, and then position change. These are
That's
all
beautiful.
actions that you can perform to for comfort measures. And then you can encourage what you call the partner to also stroke on the abdomen. Okay. They are all comfort measures. You offer them fluids and then some form of ice cubes to prevent dry mouth and the lips. And then you encourage them to void every 1 to 2 hours. Okay. Um, so these are also what you do. For the interventions, yes, it's not quite difficult, but what mostly treat people is how often the contraction should occur and then how long the contraction should last for. This is where, if you are here, you should pay much attention to. So 3 to 5 minutes, that is how often contractions will occur. So the same thing, if someone is inactive and then the person is contracting every 2 minutes, it is not normal. Okay. If 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 someone is in the active, if the person is in the active phase of labor, you don't expect the person to be contracting every 2 minutes. It is not normal. Active is what? 3 to 5 minutes, lasting for 30 to 60 seconds. Then the last phase of stage one is the transition. So transitioning, the person is moving to a new stage. Okay, so transition is where the woman dilate from 8 to 10 cm. 8 to 10 cm when the woman become fully dilated. Okay, and so this is where you expect contractions to occur very closer together. So contraction will occur much more closer together every 2 to 3 minutes. Okay, every 2 to 3 minutes, contraction should be occurring. Then the contraction will now last longer, 45 seconds to 90 seconds. So this is where you expect contraction to last for 90 seconds. So again, if contractions are lasting for 100 seconds or 120 seconds in the transition phase, it is not also normal. Okay. And then if it's also lasting for, let's say, 30 seconds, it is not normal. It should be 45 to 90 seconds. That is how long contraction should last for. Okay. And now the pain become more intense. So stronger in intensity in terms of the pain. So this is transition. Okay. Over here, we encourage rest between contractions. You wake the client up at the beginning of contraction to begin breathing patterns, okay? And then you keep the clients and the partner informed regarding progress. Now, you need to provide privacy because at this point, the woman is moving to stage 2, which is the delivery of the baby. And so at this point, you have to ensure that you are providing privacy so that if you have to expose the woman, nearby people will not see the woman. You have to ensure privacy now because the woman is moving to stage 2 now after transition. You offer fluids, as we said in our previous slide, and then ice cubes, ointment for dry mouth and all that, and dry lips. You also have to encourage the woman to also void every 1 to 2 hours. This is what we call the transition phase. And that brings us to an end on stage 1. And so at this point, the woman had passed
Who
stage
shot
1.
Mark and Money?
At this point, the woman had passed stage 1. The person is moving into stage
Ai, ka
2.
shafi fama da karfuni.
The person is moving into stage, what do you call stage 2 now, where the person is going to um the person is going into labor now or going to deliver. Okay, the person is now going to bring out the baby. So the stage 2 is where you have cervix fully dilated. So cervix become fully dilated at 10 cm. At this point, progress of labor is measured by the descent. So this is where the descent comes in. Remember descent, right? We said, descent, the baby will move from the negative into, station 0, then into positive station. And so you have to check what we call the descent of the baby. The head, through the birth canal, and then so that is change in fetal station, as I spoke of that was yesterday. And so at this point, you have to now do your assessment to see how the presenting part has engaged with what we call the pelvis and that of, the cervix. Okay. If the presenting part has engaged with what we call the pelvis, then it means that it's now descending as expected, or it's coming as expected. So at stage 2, you don't expect that station to be in negative numbers, as I explained yesterday. And so if someone is fully dilated at 10 cm and the person has moved to stage 2, the person is likely going to give birth in just some few minutes. Okay, so at this point, the baby should have descended enough for you to say that station should be station should be in the positive numbers. I hope you are getting the explanation I'm trying to. So here, stage 2, contraction continues to occur every 2 to 3 minutes, lasting for 60 to 75 seconds. Okay, and then the pain continues to be stronger. You expect to see bloody show. Okay, because at this point the baby is likely coming. So increase in bloody show, and then the pregnant client feels the urge to push, and that is called Ferguson reflex. So you assist the client in pushing. So at this point, the client feels something is around or something is at the rectum. Our mothers here, you know what it means, right? And so you feel the urge to push now. And so over here, what you do for the mother is to perform your assessment every 5 minutes. You monitor the vital signs, and then you monitor fetal heart rate, very important, with your Doppler. And so this is where if the woman is experienced, you are likely going to see if there is let's say variable decel, or there is cord coming out first, and then the presenting part is exerting pressure on what you call the cord. This is where you will be seeing those kind of abnormal heart rate traces. Kindly mute up for one. So you continue to monitor the fetal heart rate. Very, very important. Either with your Doppler, your fetoscope, or your monitor that you are using for your monitoring. Let me mute this person up. Okay. All right. So you will have to continue to monitor. Then you assess fetal heart rates, as I said, during and after contraction. You have to noting the normal. We spoke about normal yesterday. The normal fetal heart rate is what? Between 110 to 160. This is what you expect to see. Then there's going to be some form of fluctuation along the line. Okay. If fetal heart rate is dropping, it drops below 100 and then it stays there forever or stays for a very long time, you know that there is fetal bradycardia. It's not a good sign. Okay. But you can have a little drop, especially early decel. So early decel can happen. And then the fetal heart rate will drop to about, let's say, 105 and quickly returns back to the baseline. And you should know that that is early decel, especially when the presenting part has engaged with the pelvis, right? Or when the presenting part has engaged with the soft tissues. You expect that there will be what you call early decel, which is normal. But for late decel, it will drop below 100. And then when it even drops, it will stay for a very long time, more than 10 minutes. And then it's not returning back to the baseline. Those are the things that will require you to inform the healthcare provider. Okay. You monitor contractions as well. How long it's occurring. Is the woman experiencing uterine activity? And so hyperuterine activity is where you are having contraction occur very closer together. Every 1 minute, the woman is contracting. You know, it is not normal. Even in transition, we said that contraction should be occurring every 2 to 3 minutes, right? Every
Which one
3
do you
minutes,
want?
contraction should be occurring. And
Which
so
one do you want? One touching.
if you have someone who is contracting every 1 minute or 60 seconds, know that that is hyperurethral activity, which is not a good sign. And so you need to report, okay? Then you provide clients with encouragement and praises and all that. Don't go and beat them. You provide rest, okay, between contractions. You keep them informed regarding, progress. Privacy is very important. You can provide some form of ice cubes, IV fluids as well. Sorry, fluids, right? And then assist the client into a position that promotes comfort, facilitates, pushing. So probably lithotomy, semi-sitting, kneeling, sidelining, or squatting, depending which one at the moment is appropriate. But you know that all these can be used in delivery, right? Where I work, they say they tend to use the squatting because the local people use the squatting. So when the baby is coming, they want to squat so that the baby can easily come. So they say they've created a hole that looks like, what is in the house or how they feel like when you are delivering in the house. But depending, you can use the lithotomy and all that to deliver your baby, depending on the situation, right? And so our midwives over here, you know which one you use for your delivery. Monitor for signs of approaching birth. And so signs of approaching birth is where you have perineal bulging or visualization of what we call the head or the presenting part. So you can easily see the presenting part, within the canal. And so you prepare to receive your baby. Okay, so from there, this is practical. So you have to go to the ward and then practice. And so you deliver your baby now. After the presenting part has passed through the canal, you can see the baby. So you assist to deliver. So expulsion of the baby. So the moment you deliver the baby, stage 2 has ended. So stage 2 start from when the cervix is fully dilated up to when the baby is finally delivered. Okay, up to when the baby is delivered. That brings you to an end to stage 2. You then go to stage 3. So stage 3 mainly has to do with delivery of the placenta. After the baby is delivered, you need to deliver the placenta. And so that is stage 3. So stage 3, you need contractions to deliver what you call the placenta. So stage 3, I said delivering of the placenta is stage 3. Contractions occur until the placenta is expelled, right? Remember that at stage 1, the purpose of contraction in stage 1 is to ensure that the cervix is dilating. The purpose of contraction in stage 2 is to deliver the baby. Then the purpose of contractions in stage 3 is to deliver the placenta. When we go into stage 4, where that is the first 4 hours after the placenta has delivered, the purpose of contraction is to also to prevent postpartum hemorrhage. So if the if the uterus is not contracting adequately in the stage 4, the woman is likely going to experience PPH. So contractions at each of the stage has its significance. And we all need to know. Stage 1 is for dilation. Stage 2 is for delivery of the baby. Stage 3, what we are coming to do now, is for delivery of what we call the placenta. And so if the woman delivers the baby and then contraction stops, placenta will be retained in. And so you might have to massage, you might have to give your oxytocin to enhance what you call contractions. Okay. So we'll talk about the complications. And so we get to know all the issues that has to do with placenta retaining in and all that. Okay. So let's continue. So stage 3, I said contractions occur until the placenta is expelled. Placenta separation and expulsion will now occur. And so you then deliver what you call the placenta. Expulsion of the placenta occurs, within 5 to 30 minutes after the baby is delivered. The most important thing here, everyone, the most important thing here, during or after the cervix has dilated, after the placenta has been delivered, the most important thing here is to assess to make sure that all the placenta, in terms of assessment, you have to make sure that it's intact. Nothing has been retained. Okay, no placenta product had been retained. And so we say that during stage 3, when you deliver the placenta, you do assessment. The assessment you are doing to find out if all the vessels are intact. And so we use this. We say that ever means it's supposed to be AVA if you want, AVA, for you to remember. It means that when you are doing your placenta assessment, what are you looking for? You are looking for 2 arteries and a vein. Okay, and so what it means is that the placenta is made up of 2 arteries and a vein. So 1 vein and 2 arteries, when you are doing assessment, that is what you are looking for. So when you do assessment and you are exporting only a vein, okay, this is how the NCLEX will ask. That's why I'm taking my time to do this. So if you read your question and then it says that after the placenta was delivered on assessment, how many arteries in a vein, how many vessels you expect to see? That is how they put the question. How many vessels you expect to see? And so on assessment, you expect to see 2 arteries and a vein, not 2 veins and then 1 artery. That is wrong. So it is 2 arteries and then a vein. That is one thing they like asking. So you have to make sure that on assessment of the placenta, all the vessels are intact. If the vessels are not intact, what it means is that there might have been a retained vessel or a retained product, which can cause postpartum hemorrhage. And so make sure that you are doing your placenta assessment after the placenta has been delivered to be sure that all the vessels, okay, are intact. There is no any retained vessel or products within the uterus that could cause postpartum hemorrhage. As for this is it Schizzel's mechanism and then Duncan mechanism are not of any it's not, I haven't seen question, just that I just kept it. That is how the cervix after you have delivered the placenta, how it looks like. Okay, so you have center portion of the placenta separating first if you are using this mechanism to deliver your placenta, and then it looks shiny and then emerges out of the placenta. If you are using Duncan mechanism to also deliver the placenta, the margin of the placenta separates and it looks dull, rough, and then rough maternal surface emerge from the vagina first. These are they don't really like asking questions about it. It's of no, whichever mechanism you are using to deliver the placenta is not of much interest. The important thing is after you have delivered the placenta, make sure that all part of the placenta is intact and there is no retained portion or retained product of it inside the uterus. Now, on assessment, you assess during what you call your stage 3, you assess vital signs, you assess uterine status. And so if the uterus is not contracting within the stage 3, I said that it will be very difficult for you to deliver the placenta, right? So you have to make sure that the uterus is contracting adequately as expected. Then you provide parents with explanation on why you have to deliver the placenta. Okay. And then after expulsion of the placenta, uterus has the uterine fundus remain firm and is located 2 finger breadth below the umbilicus. This is the normal thing that you have to see after you have delivered the placenta. If you deliver the placenta and then the uterus is deviated to the side. Okay. And then it is not firm and it is bulgy. It is an abnormal finding. So after delivering the placenta, and then the uterus remain deviated to the side, and then it is bulgy. If they use the word bulgy, it is not a good sign. It means that the uterus is either shifted, okay, it's shifted. Mostly what causes it is when the bladder is full. So the bladder can shift what you call the uterus to the side, and then so that that will make the uterus not to be able to contract adequately. And so after you deliver what you call the placenta, you have to make sure that you are doing your assessment to make sure that the uterus is in the midline position or remains firm, okay? And then it has to be in midline. And then it has to also be 2-finger breadth below what we call the umbilicus. If it is above the umbilicus, it is not a good sign. It means that the uterus is bulgy. The uterus has to be firm, indicating that it is contracting after the placenta has been delivered to prevent postpartum hemorrhage. And so if you do your assessment and then you realize that the uterus has deviated, it is bulgy, the first thing you do is to assess for what we call the bladder. Okay, so he said that the first thing you do is to assess the woman to empty the bladder. If it is not the bladder that is full, you have to massage what we call the uterus. When you massage, it will then contract. Okay, so these are what you do for the woman who is in labor or when you have delivered the placenta. You have to examine placenta for cotyledons and then membranes to verify that it is intact. So that is what I was talking about. You have to assess to make sure that all the membranes are intact, the vessels are intact. So I said that it has 3 vessels, 2 arteries, and a vein, right? So assess to make sure that they are all intact. Assess the clients for shivering, and then you provide warmth, you promote attachments where you give the baby to the mother for the mother to hold the baby up and all that. So promotes parental and the neonatal attachment, which is very important. Bonding, right? And so after you deliver the baby, you have to give the baby to the mother for bonding to continue from there. That will bring us to an end on stage 3.
Hello.
So stage 3 is after the placenta has been delivered. Yeah. A
Hello.
question? Yeah.
Yes, please.
Mm.
Please,
Mhm.
I would like to know whether there is any scientific backing with regards to the shivering after delivery.
The reason why the woman could shiver. So what do you think could be the reason why the woman? I'm also thinking, what are some of the things that would make the woman to be shivering after the placenta or after you have delivered the baby? Okay, so I'm still thinking, right? Maybe it could be after the delivery. There's a change in should I say physiological changes. It could be probably maybe some blood loss could cause definitely when you deliver, you're going to lose some amount of blood. And all that could also cause the woman to shiver. And then probably maybe when during delivery, the woman is in where you deliver the woman over the AC and other things. So after delivery, the woman is going to feel some form of chillness and all that. But that is what I'm thinking. Okay. And so after you deliver and then the person is feeling that chillness of their body, you might have to provide some warmness, clothes to cover up and all that. Any further question? Okay. Let's go into stage 4, the last stage of the various stages. And so stage 4 is after you deliver the baby. Sorry, after the placenta is delivered. Okay, someone also says that the misoprostol can also cause it. Okay, and so we are giving misoprostol to also enhance contraction and all that. And so someone is also saying that misoprostol can also cause it. All right, thank you. All right, so let's look at the last stage. That is the first 4 hours. So that is the golden hour, the first 4 hours after the placenta had been delivered. I mean, it's golden hour, right? Or the first 4 hours is very important. After you have delivered your placenta, that immediate 4 hours, or the first 4 hours after the placenta has been delivered, if the woman is going to experience any form of postpartum complication or postpartum hemorrhage, it mostly happens within the first 4 hours, even though it can happen even after, I mean, days, okay, after delivery, days after delivery, the woman can still experience postpartum hemorrhage. But if it will happen, it mostly occurs within the first 4 hours. Okay, so within the first 4 hours, you need to critically monitor the woman. You monitor how often the woman is changing pad, or how often you're changing the pad. Okay, you monitor vital signs, blood pressure, to be sure that it has returned back to the pre-labor level, and then the woman is not experiencing hypotension. And so you have to monitor the woman very well within the first 4 hours after the placenta is delivered. Okay, so let's go into it. So stage 1, oh sorry, stage 4, that is the 1 to 4 hours after birth, right? The assessment you do. So over here, blood pressure will return to pre-labor level where it was before the person went into labor, and then pulse will slightly be a little bit lower than expected. Okay, and then the fundus will remain contracted. So these are things you have to see within that period, within the stage 4. The fundus should remain contracted, okay? And then in the midline, 1 or 2 finger breadths below the umbilicus, just like I explained. That will tell you that the uterus is contracting. You monitor for discharge. We talk about lochia. Okay, we talk about rubra, we talk about serosa, and then alba. I mean, probably maybe next week we'll talk about those ones. So you know the difference between the various lochias, okay, and then when each of them occurs. So you have to monitor lochia. Lochia is the fluid that comes out after delivery, or blood that comes out, even though it changes color as time goes on, up to 2 weeks after delivery, from bright red to, I mean, white, or yes, if you want white, it changes up to white up until it turns white. So you monitor for discharge, that is lochia. Lochia may be moderate in amount, and then it has to be red in color in the stage 4, because that is the immediate fluid or the immediate blood this woman is going to lose after delivery, right? And so over here, what are the things you do? Assessment. How often should you be doing your assessment? So within the first 1 hour, we're saying that the stage 4 is the first 4 hours after the delivery. But within that 4 hours, we have divided, I mean, how the assessment should be done, or how often the assessment should be done. So you perform your assessment every 15 minutes within the first 1 hour. So within the first 1 hour, you do 15-minute assessment. So that means you're going to do 4 assessments. Every 15 minutes you do, within the first 4 hours. Then the second hour, right? The second hour, you do assessment every 30 minutes. So that will give you 2 assessments every 30 minutes. And then the last 2 hours, you do 1 hourly. Okay, so you do 1 hourly, then you get the 4 hours. So look at it very well. I said that the first 1 hour within the first 4 hours, you do 15 minutes. Okay. And so that is 4 times and you get 1 hour. Then the second hour, you do 30 minutes assessment. That will be 2. And then that will give you another hour, and that will be 2 hours, right? Then the last 2 hours, you do assessment every 1 hour. So that will be 2. And so in all, you do about 6 assessments. No, eight rather. You do 8 times assessments within the 4 hours. So every 15 minutes, then every 30 minutes, then hourly. I hope you get me. What are you assessing? You are assessing vital signs. You are assessing lochia. You are assessing the what do you call the pad to be to see whether the pad is fully soaked. And so we say that if the pad is fully soaked and you are changing the pad multiple times, okay, within the first, let's say within the first 1 hour, you are changing the pad multiple times, and then anytime you check you change the pad is fully soaked or 100% soaked, it means that the woman is probably bleeding. So you have to report. So you provide warm blankets, you provide ice pack to the perineum. And so, for instance, if they did episiotomy, or if let's say the woman got a cut, there's going to be some form of pain. And so, in managing the pain, some of the non-pharmacological intervention you can apply is ice pack around the perineum to lessen the pain, and then also for vessel to constrict to prevent bleeding, right? Then you also massage the uterus if needed, and then you teach the woman how to massage the uterus. Remember, I said that the uterus has to contract during this stage to prevent postpartum hemorrhage or to prevent bleeding. So during your assessment, if you notice that the uterus is deviated, the uterus is shifted to the side, and it is bulgy, it means that it needs to be massaged. Okay. And then you provide what you call breastfeeding. You initiate breastfeeding from here. You have to encourage the mother to breastfeed as much as the mother can breastfeed the baby, right? And so provide breastfeeding and then chest feeding support as needed. And that is the stage 4. So stage 4, it has to do mainly with assessment to be sure that the woman is not bleeding. All right. We know that if the woman is bleeding, it's going to affect the blood pressure. The pulse will also go very high. There's going to be tachycardia. And then you'll be changing the pad more frequently. And anytime you change, you notice that the pad will be completely soaked. These are all things that will help you to know that the woman is experiencing postpartum hemorrhage. That is that for the stages of labor up to stage 4. Any question on the stages of labor? If you have a question, if you have an input, you can bring it up, and then we quickly do our questions from there. We'll go into the other things we need to do. Any questions? Someone says she can't hear me. I think someone has even responded that I'm loud, right? So if you cannot hear, kindly leave and join. Log out and then log in again. You can hear me. Right? Okay. So that is that for this part. Any input, any question, any addition, anything you want to ask, you can bring it up before we do our questions. Okay. Okay. All right. So let's go into the questions if there's no. So I have a question on the screen. Hey, my laptop is going off.
Auntie Abby. Auntie Abby. Auntie. I don't know what happened. Your phone is doing like auntie. The Zoom is not coming. Where's my popcorn?
I think the owner is off. Hmm? Ambala. You've not done one. See. She will be.
Ma, they are not used to
Who won it? D. She will be. Who won it?
Hello, Chris. Hello.
Hi. Hi.
Yeah, I think Amingo is having network issues today, so kindly bear with him, okay? Yeah.
Back it wasn't that way this time around. But I don't know when I had unplugged my piece, so it just went off. Sorry. So, all right. I hope the recording is still on. Okay. Let's see. Yeah, it's still on. All right. So we're just looking at questions, and then my PC just went off, right? Okay. So let's look at this question. But then if you have any question, any inputs on what we just did, you can you can bring it up, okay? If you have any issue, anything you want. These are simple questions, right? So let's look at this. A laboring client reports feeling the need to have a bowel movement and then begins vomiting. The nurse notes that the client's legs are trembling. What cervical examination findings would the nurse most expect this client to have? We have one, 2 cm dilated, 50% effaced, -2 station. We have 2, 6 cm dilated, 70% effaced, -1 station. 3, 7 cm dilated, 80% effaced, and then 0 station. And then 8 cm dilated, 100% effaced, positive one station. So for a client having this assessment or telling you that she feels the urge um to have a bowel movement and then begins vomiting, the legs are trembling as well. Which of this cervical assessment do you expect to note in a client with such complaints? This is very simple. If you've been with me and then have paid attention to all that we are doing. Okay, this is simple, right? So we expect and then the station should also be a very good station, not a bad one, right? So with that, the fourth one is the answer as you guys selected. Is there anyone who is struggling to understand it? Okay, let's look at this. The nurse is caring for a client in labor. Which assessment findings indicate to the nurse that the client is beginning the second stage of labor? Listen, read the question very well. Which assessment findings indicate to the nurse that the client is beginning the second stage of labor? Select all that apply. 1, the contractions are regular. 2, the membranes have ruptured. 3, the cervix is dilated completely. Then 4, the client begins to expel clear vaginal fluid. And then 5, the Ferguson reflex is initiated from perineal pressure.
Please, Brother Mingo, sorry to cut you short there. The last one, I chose number 4, but my network went off. I don't know if I was correct.
Yes, you were correct. That was the answer. So this is the rationale. It's on the screen.
Oh, okay. Okay.
Let's come back to this question. Mm-hmm. Mm-hmm. Okay, I'm getting 531, 531, 531. Okay. Mm-hmm. Hey, someone say all of it. Someone said all of it. All of it. Yes. See, the question wants which of these is peculiar to stage 2. Okay, that is what the question wants. The question wants which of these assessments is peculiar to stage 2. Okay. Mhm. So that is what the question is demanding. We know that almost all the things can be seen or clients can experience it, but which of them is much more specific for stage 2? Okay. Now I hope it is clear. So now I expect now I have made it clear. It should be easy. All right. Okay, so let's proceed. So it's 3-5. Someone had it. So, like I said, the question wants what is specific to what is specific to the stage 2. Okay. What is specific to the stage 2? Hmm. So the rationale is on the screen. Is there someone who still wants to contest the answers? Okay, so let's progress. Please, if you want any clarification on anything, kindly feel free to bring it up. Okay.
Please, the second one, why did you choose only the 3 and 5?
Only the 3 and 5. What was your answer selection?
3, 1, and 5.
3, 1, and 5. Okay. So just like I said, the question wants answers that are specific to only the stage 2. Yes, we know that contractions will occur and the contractions will be regular, but that contraction doesn't happen only in stage 2. In stage 1, contractions should be regular. Stage 2, stage 3, contractions should also even occur. Okay. And then but we are looking at stage 2. What is in stage 2 that will tell you that this person, or what kind of assessment will help you to know that this person is in stage 2? Not, you cannot use contractions to say that because the person is contracting regularly, the person is in stage 2. But the moment you know that the person has dilated, it means that the person has entered into stage 2. And the moment the Ferguson reflex is initiated, that means that you are to deliver the baby. So these are peculiar to stage 2. I don't know whether you are getting the analogy here.
Yeah.
Contraction occurring regularly isn't something that you can base on it and say that because contractions are occurring regularly, it is stage 2 the person is experiencing. No. The same thing, ruptured membrane can happen. I mean, within stage 1, membranes can rupture. And then, yesterday also, we learned that show can happen even days before the person goes into labor. So it is not I've been quite specific. Okay.
Okay.
Mhm. The nurse in the labor room is caring for a client in the active stage of the first phase of labor. Active stage of the first phase of labor. The nurse is assessing the fetal pattern and note a late D cell and note a late deceleration on the monitor strip. What is the most appropriate nursing action? A or 1, administer oxygen via face mask. 2, place the client in a supine position. 3, increase the rate of oxytocin infusion. Then 4, document the findings and continue to monitor the fetal patterns. This is very simple, right? I guess it's not difficult. Someone was asking what is the correct answer. Is it to the previous question? It was 3-5. It was on the screen for some time while I was even trying to explain. This is the answer, 3-5, right? Mm-hmm. Hey, a question on the screen, or it's not showing. There is a question on the screen. No one has attempted yet, or it's not showing up.
This is one. It's one.
It's 1.
Yeah, we know that how do you call late diesel is caused by placenta insufficiency, so we would have to give oxygen.
Okay. Okay. So she says it is 1. Mhm. The nurse is performing an assessment on the client's schedule for cesarean section at 39 weeks gestation, which findings indicate to the nurse to contact the primary healthcare provider. Hemoglobin level of 11, fetal heart rate of 180 beats per minute, maternal pulse of 85, and then WBC of 12,000. This is also simple, right? Okay. Oh, I show the answer, but I guess everyone here knows why the answer is 2, right? We spoke about normal fetal heart rate, right? So if someone is experiencing 120, sorry, 180, it demands you It demands you to report to the healthcare provider. Now let's look at this question. The nurse is monitoring a client in active labor and notes that the client is having contractions every 3 minutes. That lasts 45 seconds. The nurse notes that the fetal heart rate between contraction is 100 beats per minute. Which nursing action is most appropriate? We have 1, notify the healthcare provider. 2, continue to monitor the fetal heart rate. 3, encourage the client to continue pushing with each contraction. And then 4, instruct the client coach to continue to encourage breathing technique. I'm seeing 1, I'm seeing 2. Okay, so let me see what people are choosing. Is there anyone to defend his or her answer? It's not certain. So someone is going for 1, 2. It's not certain. It's select only 1. Okay. So someone says notify. Someone says continue to monitor. So why are we continuing to monitor? And why should we notify the healthcare provider? Those going for continue to monitor and those going for notify the healthcare provider. Tell us more on why you're going for. Okay, Ophelia, your hand is up.
Yes, please. For me, I chose 1 because the question says that the contraction happen, the fetal heart rate between contractions. So it is likely that it is late decel because it's the fetal heart rate 100 beats per minute is not recorded with the contraction. That's why. So if it is late decel, for the option given here, there was no any room for intervention. So I would have to notify the primary healthcare provider. That's why I went for 1.
Okay, all right. All right. She has given us her rationale. Convinced us, tried to convince us. Let's look at the other people. Pat. Okay, Pat, try to convince us as well. Okay,
Please, I
Pat,
was
let's.
also thinking that fetal heart rate of 100 beats per minute is bradycardia. So I have to inform the healthcare provider because it's supposed to be 110 to 160. That is why I chose 1. I chose yes, 1.
So she's also saying that she thinks that it is 1, that it's 100, so it's fetal bradycardia and needs to be reported to the healthcare provider. Last person, if you want to talk, then we go on. If not, we'll proceed. Okay, that's great. So you did very well, right? So those going for two, you looked at the rationale that Ophelia gave as well as Pat also gave. I like the Ophelia's point. You look at when the contractions are occurring. So the contractions are not occurring together with, I'm sorry, the fetal heart rate is not dropping together with contractions. And so for you to say that it's early decel, okay, that you say you continue to monitor. But this time around, the fetal heart rate is dropping in between contractions. So that is late decel, right? So after contractions ends, then the drop happens. So it's happening in between contractions, which is likely an indication of decel dropping, that is bradycardia, right? Just as also Pat also said. So there's fetal bradycardia there, and it's happening in between contraction, which is not good. Okay. I hope we pick something from this question. Right. Okay. Or there's someone who wants to ask. If you feel like you need to ask, kindly ask, okay. If you have anything you want to point it out, kindly point it out. We go. Right. Okay. The nurse is assisting a client. Probably this will
Or
be
you not go.
maybe our last
Go and
question.
bring your medicine.
The last two, then we move on. The nurse is assessing. Sorry, the nurse is assisting a client undergoing induction of labor at 41 weeks, weeks of gestation. The client's contractions are moderate and occurring every 2 to 6 minutes. Sorry, every 2 to 3 minutes with duration of 60 seconds. An internal fetal heart rate monitor is in place. The baseline fetal heart rate has been 120 to 123 beat per minute for the past hour. What is the priority nursing action? 1, discontinue the infusion of the oxytocin. 2, notify the primary healthcare provider. 3, place oxygen on at 8 to 10 liter per minute via face mask. Then 4, contact the client's primary support if not currently present. All right. So now you understand, right? I'm glad that you people are able to do this, okay? So the priority at this point, we need to stop the oxytocin, right? So you have to stop the oxytocin before any other action will be taken. Okay. The contractions, so the oxytocin can cause forceful uterine contractions and decrease oxygenation to the placenta, resulting in decreased viability. And so here, I hope you know why we are stopping. What is wrong with the question? I hope you guys know what is wrong with the question. It has to do with viability, right? Yesterday we spoke about viability. So look at what has been the fetal heart rate. So the question looks like there's nothing wrong with the question. I don't know whether you guys notice it. So the uterine contractions, I think it also occurring much more closer because this is active, right? So active should be 3 to 5 minutes, right? Okay, so active should be every 3 to 5 minutes. And then when it happens, we say it stays for how long? It stays for how long?
30 to 60
to
seconds.
60 seconds.
60 seconds, right? So as for how long the duration is fine, but the frequency at which it is happening is too much. Then another thing to look at how long the fetal heart rate had stayed. That stayed at 122, 122. I mean, viability is not quite good, right? So we said that viability is where you have the up and down swinging of what you call the fetal heart rate, okay? But it has stayed at this point for a very long time. I mean, it's not really good, okay? We said we need a moderate viability for you to be sure that the fetus is actually doing well. And the cause of the so here one, there's hyperuterine contraction because contractions are occurring faster. And then two, there is also issue with viability. And then the cause of it is because of the client receiving the pitocin or the oxytocin. So the priority action here will be to stop the oxytocin. The moment stopping the oxytocin can resolve the problem, right? And not calling the healthcare provider and not giving the oxygen. Of course, giving the oxygen might help, but if you give the oxygen and then the oxytocin is still running, you are doing a cost 90 job. I hope you get the question right. So that is so for those probably who did not yes, in such question, yes, you'll be able to get the answer right, but understanding the rationale is also very important. Okay. So that's I mean probably maybe you get a similar question somewhere and then you'll be able to analyze it well, look at the parameters inside the question, and then what's probably wrong with the question so you can come up with your answer.
Sorry.
I hope that's clear. All right.
I didn't get hello.
Yes, hello.
Please, I didn't get why. Sorry, I didn't get. I wasn't. My network wasn't good. I didn't get why you said we should stop the oxytocin.
You said you don't know why we are saying we should stop the oxytocin.
I didn't get why we are stopping the oxytocin. Yeah, you said that's the right answer.
Hi. Okay.
Sorry.
Who explain it again for us? Sally was out when I was doing the explanation. Who wants to come in? And so Sally will get a better explanation. Where is the question? So this is the question. Who wants to re-echo what I said? But Sally, what would you have chosen if you have to choose? What would you have done here?
Notify the healthcare provider.
You inform the healthcare provider.
Yes.
Okay, why would you inform the healthcare provider instead of stopping oxytocin?
Okay. I will inform the healthcare provider because the duration is 60 and the heart rate is 120 to 122 for past hours. That means it's not moving, it's just at the place. So that's informing the healthcare provider.
Okay, Sally, thank you. Now, Sally says she will go for 2 because she thinks that the duration of the contraction is 60 seconds and then the fetal heart rate had stayed constant for quite some time. So she will inform the healthcare provider. But Sally, there's something in the question that is causing the problem, which is the oxytocin. Okay, there's something going on. Remember, client is undergoing induction, and then in induction, I don't know. I think the question even wasn't, they didn't mention oxytocin, but the moment you know that someone is going through induction, induction is done with oxytocin. So you might say that, okay, the oxytocin is not mentioned. It's not mentioned that client is taking oxytocin. So why are we stopping oxytocin? But remember, client is undergoing induction, and induction requires the administration of what they call oxytocin to enhance contractions, right? But this time around, the problem that is going on is because of the induction, is because of the oxytocin that is on. So the first and the best action here you can take will be to stop the oxytocin, because if you stop the oxytocin, you have stopped the problem that is ongoing, and that could salvage the situation instead of going to inform the healthcare provider. Yes, you need to inform the healthcare provider, but that is not the first and the priority action here. The first and the priority action will still remain that stop the oxytocin that is ongoing. The oxytocin, as for the duration is even fine, because we said that duration for active, remember client is in active labor, right? It stated that client is in active, I think so. And so that should be about 60 seconds is fine. But how it's also occurring 2 to 3 minutes, right? But then what you should be worried about is much more of the viability, because the fetal heart rate had remained forever, or had remained constant for a very long time. And we said that there has to be moderate viability. If you have absent or decreased viability, it is not a good thing, and you need to inform the healthcare provider. But look at what is causing it. If there is something that is causing it, the first thing to do will be to stop that thing, and that will also be the priority here. Because if you inform the healthcare provider instruction will still be to stop the oxytocin. So knowing this, you have to also know that your priority action will be to stop the oxytocin. And then later, subsequently, you inform your healthcare provider. Okay. So, okay. Ahead. Any other question? Any other inputs? Last one, then we move on. The next is caring for a client immediately after a vaginal birth. The nurse notes that the client's uterus is midline and then bulgy. Which of the following actions should the nurse take first? 1, perform uterine fundal massage. Then 2, increase the rate of oxytocin infusion. 3, obtain the client's blood pressure and pulse. 4, check for pool blood under the client's buttocks. So this one is also easy and simple as ABC, right? We said this, the cause of the uterus being bulgy and then not in the midline is because okay, it says it's in the midline and it's bulgy, right? But the problem here is the bulginess, and it indicates that the uterus is not contracting adequately. So you need to massage. Okay, you need to perform actions that will assist with the uterine contractions. Okay. Any further question, any inputs before we proceed? Before we proceed, any question, any inputs, anything? Okay. So that brings us to an end to stages of labor, what we need to know. That might not be all, but at least we've done a lot on that. We will be answering questions whilst we keep on studying. If you have already done maternity, fine. That is in your schedule you've been given. If you are yet to do, when you get there, you will go over all this again, and then you will now answer your questions and all that. Okay. All right. So that is that for what we have to do for the first part of today. So today I'll take a little bit of your time because of the network issues I had. So by 6:30, I'll be closing around 6:30. Just bear with me, okay? Just to make up for the time we lost. All right. So we are looking at some of the problems that could occur during labor, or some of the complications that could occur during labor, and how we're going to manage it. Okay. So problems with labor and birth. That is what we are doing now. So the first thing we'll look at is premature rupture of the membranes. What will happen, or what should you do when membranes ruptures? Okay. When membranes ruptures, what do you do? And then what are some of the interventions? What do you monitor? Okay. What do you monitor? What do you do? What actions do you do for someone who ruptures the membranes? Okay. Now, one main thing that you should take note of is infection when it comes to premature rupture of membranes. Infection is one of the main things that, if membrane ruptures, you want to prevent. Okay, so let's put it at the back of our mind that infection is one of the main things that, when membranes ruptures, you want to prevent. Because when the membranes rupture, there is what we call high risks of infection, and the infection that is vaginal infection that could affect what you call the fetus. And so we want to prevent infection during ruptured membranes. And you know that when membranes ruptures and then the person is also not at term gestation, there's a likelihood that the person is probably going to experience preterm labor and all that. Okay, so premature rupture of membranes will happen when you have a spontaneous rupture of amniotic fluid, or the amniotic membranes, before the onset of labor. That is why rupturing of the membrane alone is not enough for you to say the person is in active labor. But then we know that, membrane should rupture during labor. And then we have people where the membranes ruptures even before labor sets in. Okay. And when that happens, the person becomes at high risk of what we call infection. Usually, when membranes ruptures, what we want to know is what is the gestational age of the fetus. So the gestational age will also kind of guide on what should be the intervention or what should be the action. Like I said, if the person is not at term and then membrane ruptures, one, premature labor is there, infection is also a concern. But if the person is already at term gestation, it's not much of a problem, because we can induce labor from there, and then labor continues if the person is at term gestation. Okay, so gestational age usually determines the plan and the intervention. When the rupture of the membrane is before term, and then birth will be delayed, infection becomes a risk. That is what I just said. So action largely depends on what is the gestational age. if the person is attend, no problem. We can induce labor for the person to deliver just to prevent complications of infection. But if the person is not at 10, let's say 33 weeks, and the person has lost or the membranes have ruptured, remember, infection here is a concern. And because you might want to delay the delivery, or you might want to delay labor for some time until what you call the lungs are fully matured, and then you can then deliver the fetus or the baby. And so during that waiting period, infection is a concern. So how will you know that one is experiencing premature, or one is having premature rupture of the membranes? One is the presence of fluid pooling in the vaginal vaults. And then when you see the fluid, don't just conclude that it is amniotic fluid. We do something we call nitrogen tests. So everyone here should be able to know what nitrogen test is. So nitrogen test is done to confirm if the amniotic fluid, or if the fluid that is in the canal or in the vagina is what we call actually amniotic fluid. Okay. So we use the nitrogen. It's just like when we were in school and then we're doing acid and base, and we're testing for whether a substance is acid or a base using litmus paper. And so it's the same process you do. And so we have something we call the nitrogen paper. And so you dip the nitrogen paper into the fluid, and then there's going to be a color change. Okay. And so if usually what will help you to know that it is amniotic fluid is that the color of the nitrogen paper has to change to blue color. So when you have a blue or a blue green change, it tells you that it is what you call amniotic fluid that is there. So I said that nitrogen test is done to determine if the fluid that is coming out is amniotic fluid. And so the nitrogen test is just like a litmus paper, where you use to test the acidity or the alkaline or the alkalinity of what you call the fluid. Okay. And so if you test, we know that vaginal fluid is acidic in nature, right? And so the pH should be less than what we call 6. Okay. And when you test and then you get a yellow green color change, it is not amniotic fluid, because amniotic fluid is alkaline in nature. And so if it is amniotic fluid, the color will change to green, blue green or blue color. So the color will change to blue, and then that will tell you that it is amniotic fluid, because amniotic fluid is alkaline, and so the pH should be above 7 to 7.5 thereabout. That should be what we call the color change when you are using nitrogen. So positive nitrogen test, that is when you do it and the color change to blue, it means that it is actually amniotic fluid that is there. Then what you also have to assess for is the amount, the color, and the consistency, as well as odor. So when the fluid, let's say you test the fluid is amniotic fluid, now you have to test the odor. If it has a very bad smell, it means that the infection is at risk. Okay, so you check the amount, the color, consistency, and odor of the fluid. All needs to be assessed. Then vitals. We are saying that infection is a concern. So maternal infection that can affect what you call the fetus along the line after rupture has occurred. So you monitor vital signs, where when there is infection, temperature is likely going to be elevated. So elevated temperature may indicate infection. And then when the infection is also there, there's going to be fetal tachycardia. Okay, so you do fetal monitoring, which is necessary. Fetal tachycardia also indicate that there is maternal infection. So in your question, you can get a question on ruptured membrane. And on your assessment, they will bring, let's say, they say that you are monitoring a woman at 35 weeks of gestation or 34 weeks of gestation who complains of experiencing some fluid or some fluid coming out through the vagina. Okay. And then assessments, they say that temperature is maybe 38 point something or 101 Fahrenheit. And then fetal heart rate assessment is done. And you notice that fetal heart rate is also high. Quickly, what should come into your mind is there is a premature rupture of the membrane that is likely leading to what we call infection. Okay. So we've said that if there is infection, fetal heart rate is going to go up. So there's going to be fetal tachycardia. Maternal temperature is going to go up. And then the consistency and then the odor, okay, of the fluid, or there's going to be bad odor regarding the amniotic fluid. All that will tell you that there's a ruptured membrane and then there is an infection, pending infection. Okay. And so the nitrogen test, you also need to understand what the nitrogen test is and then how you can use the nitrogen test to confirm that it is what you call amniotic fluid. Another thing that can also give you a false positive, let me mention, a false positive result. Okay. A false positive nitrogen test can happen when there is what we call semen. When there is semen in the vagina, and then you test and you are getting the blue color change. What you have to ask the woman is, when was the last time the woman had sex? If the woman had sex not long ago, and then there's semen within the vagina, the litmus paper can also pick the semen because the semen also is alkaline in nature and can cause the litmus paper to turn blue. And so when you get litmus paper turning, sorry, the nitrogen paper turning blue, don't just conclude. You have to go ahead and ask the woman, when did the woman had the last time the woman had sex? It could be that the fluid you tested was the semen and not what we call amniotic fluid. Okay, so semen can also give you a false positive nitrogen test. When there is a ruptured membrane, what are some of the actions or some of the things you do? Your interventions after assessment and all that. You assist with your nitrogen tests you have to do, and then you assess for gestational age. Then when you do your nitrogen test and it is confirmed that it is amniotic fluid, you have to avoid vaginal examination to prevent infection. Okay, so avoid vaginal examination because of infection, or when you suspect that there is a ruptured membrane and it is prematurely, don't, vaginal examination is not encouraged in order to prevent what they call infection. You monitor for maternal and then fetal status. Remember what I said. When there is infection, maternal temperature is going to go up. When there is infection, there's going to be increase in fetal heart rate. There's going to be fetal tachycardia. Okay. Then antibiotics administration is also something that will be done to cover up for what we call the infection. Any question, any inputs on premature rupture of the membrane?
Hello, boss. Please, I want
Yeah.
to find out if there is premature rupture of the membrane. Can it be meconium stained?
I don't get the question. Yes, so
Yeah. Can it be meconium stained as well? Apart from the other, can it be meconium
yes,
stained?
yes, yes, yes. That's why I say that you have to look at the
Okay.
color and then the consistency, because the normal one must be clear, right? It must have a clear appearance and all that. But if it comes out and then it is having that meconium stain appearance, you know that it is a concern. There's a problem there. Okay. So yes, it could also be meconium stained. That is why you have to look at, apart from the odor, you have to look at the color and how it looks like. The appearance is also very important. So it could be meconium stained. And you know, meconium stain is something you don't want to see. So quickly, you arrange for cesarean delivery. I mean, regardless of the gestational age. So you are going to have a preterm labor there. Any inputs here?
Yeah, I wanted to ask something. So you said when there is a premature rupture of the membrane, the first thing we have to do the.
Kindly speak up for us.
Okay, can you hear me?
Yes, I can hear you, madam.
You said when there is a premature rupture of the membrane, the first thing we have to check, we have to do the test to be sure if it's the amniotic fluid, right?
Yes, you have to confirm if it's actually amniotic fluid.
And we also have to assess the fetal heart rate if it's going high to be sure if it's going to tachycardia.
Yes, it indicates that. So when the woman comes with a complaint of the rupture, you do assessment and you do your test and you confirm it is it's actually amniotic fluid. Then you do your vital signs and then you also monitor the fetus. So when you do your fetal assessment and then fetal heart rate is high, or there's fetal tachycardia, what could be the cause is infection, maternal infection.
Okay. So if something like this happen and it's not time for the woman to give birth, can they book the person for CS immediately or?
Yeah, so you have to. That's why remember I started by saying that the actions would depend, or the plan would depend on the gestational age. So if let's say that the person is at 33 weeks of gestation and membranes have ruptured, that is premature rupture, right? Because the person is not at 10 and then the person has ruptured. So the healthcare provider would weigh whether to keep what you call the pregnancy, depending on the state of the fetus. Okay, depending on the state of the fetus, and if probably they can prevent the infection. Okay, that will be done. But if let's say there's meconium stain, infection has set in and all that, then there's a need for the baby to be delivered. Of course, cesarean section will be done, and the baby will be taken off to prevent further complications. And so at that point, there is a preterm labor that is also a concern. I hope you are getting me. So it will be the healthcare provider who will determine whether to um kind of delay the labor or to go ahead and then deliver the baby, depending on the state of the fetus and then what could happen if they delay the labor.
Okay, I get you. Thank you.
Okay, you're welcome. Okay. Okay, thank you. Someone says I should. Okay, please, I wish we can start early. And that, okay, so I think you joined us. Sorry for that. I know that it's 18 um 20 now, which is 6:20, right? I think I pleaded. I should have stopped at 6. Yes, the problem was from me. I mean, sometimes we cannot actually have control over some of the things. Like I said, I usually start class by 4:10. I start class for those who have been with me for some time. By 4:10, I start class, but because of the issue I had with my network, that is why the class got delayed for today. So that is not our usual time of starting class. Okay, we usually start as early as 4:10 will start, but because of the delay, that's why I said I was going to do up to 6:30. So I think your concern is very genuine, and I think I have to end it here so that those who probably had other things to do, okay, because some people you have time scheduled for other activities. Some of you are at work and all that. So your concern is very genuine, Mr. Mohammed. So thank you for bringing that up. We work to rectify that. But like I said, some of the things too, we don't have